Up to
Upper extremities.
upper extremities. Okay. So in an effort to again respect your time, and also respect your energy level and your bandwidth for the rest of today, we're going to cover a quick anatomy review. Okay, and then we do have a lab for this, right? You guys saw the schedule. So we will not do both today. Okay, that's the way this course was set up originally. I changed that because staring at you guys as you're oozing into your chair after a long day on a Friday, test, junior clinic core, farm, right? Three and a half hours of farm. Exaggeration. But a lot of farm, right? It's not fair because you're not receiving what I'm sending. So therefore it's a waste of time. Okay? Okay, I don't like wasting time. There's nothing worse in the universe than wasting time. Okay? So we're going to go through this and we're going to get through it. And then when we're done, we're going to go back to studying infectious disease. Because I know that's what people want to get back to, right? Okay. You think I don't get it. I get it. I've been doing this for a long time. Okay? So, we're going to go in block 2, we're going to go into upper extremity. I find upper extremity to be fascinating because it involves a lot of fracture care. Okay? Now, I know we spent block 1 talking a lot about arthritis. Believe it or not, there's only one specialty in orthopedics that likes arthritis. What is a definitive treatment for arthritis? So who do you think likes to see arthritis? Joint replacement surgeons, right? So again, now we're going to start shifting our focus to more of the other things that we talked about, like sprains and strains, right? Ligamentous injuries and fractures. Okay, so if we're going to start talking about those kind of injuries, and those injury patterns, it's important for us to speak the same language about the anatomy that we're relating to. Does that make sense? Okay. So today we're going to start again with upper extremity imaging and really get into some of the anatomy stuff and give you guys kind of a primer, if you will. For some of you, it may be a refresher. For some of you, it's like, I should probably look at that a little bit more. Because I hope you guys agree that even though it was painful for some of you, excruciating, burning, searing, tearing, throbbing pain, right? To do an activity, right? I hope you agree that it was time well spent when you saw certain questions on an exam. Yes? Some north and south, some whatever. Okay? All right, good to go. So upper extremity musculoskeletal radiology. So when we talk about upper extremity radiology, we talk about what? Let's work our way down. Okay? So obviously we have the clavicle, the AC joint, the acromioclavicular joint. Okay? We have the shoulder joint itself, the glenohumeral joint, correct? Glenohumeral joint. We have the humerus, the elbow joint, forearm, wrist, and hand. Okay? So you do note right there that everything is listed separately, correct? So you would hopefully agree by now that if you're going to get x-rays for a particular injury, right, that you're going to get x-rays of that joint or that body part, okay? So can you see the clavicle on an AC joint image? You can, but that's not the best image if you want to evaluate a clavicle. Same thing with the shoulder, right? You can kind of see the shoulder if you get a humerus view. Would you agree? Of course you do. Okay, but if you have concern for a humerus fracture, you want to get a humerus view. Okay, so that's when we talk about MSK radiology, understand that you want to get radiographs. We all understand now, I put it under test just to be clear, radiographs are x-rays, right? Okay, in orthopedics we commonly use the term radiographs or x-rays. We don't really say plain films anymore, because we don't really do films anymore, would you agree? Right, the floppies, right, that you put up, hold up, point to it, okay? Usually when we had floppy like that, and we didn't really know what we were doing when I was young, as a PA, we just looked for what we call the fingerprint sign. It's the sign where the radiologist was pointing at the pathology the whole time they were down there, and then the films came up and we said, do you see something? Yeah, I see the fingerprint. Okay, so we can't get away with that anymore, okay? All right, so again, bony anatomy review, the same exact stuff we just talked about, right? So, but then when we work our way down, okay, then when we talk about the forearm, we have the radius and the ulna, okay? So, even though you can see the wrist in a forearm view, okay? Should you order a wrist view if you're concerned about a wrist fracture? Yes, okay? And then as we work our way down, we have the carpal bones. I want you guys to start using the word carpal bones, not wrist bones necessarily, right? The carpal bones. We have the metacarpal bones. Okay, those are the long bones, if you will, of the hand, although we don't really use that term. But the carpal bones are those little bones, right? There's a bunch of them. You guys remember what they all are, of course. Okay? Yeah, right. And then we have the phalanges. Okay, an important thing to understand about the phalanges is that, and we'll hit this right now. When we talk about the hand, do we use first digit, second digit, third digit, fourth digit, fifth digit in orthopedics? No, we don't. Okay, because very commonly people don't think the thumb is the first digit. So it's very confusing. Okay, so we use thumb, right? We use index finger, not pointer finger. That's not an orthopedic term. Okay, yeah, you can't use that, but I'm just telling you. It's an index finger, right? What's the middle finger? I don't want to give it to you, but what is the middle finger? Very commonly we call that the long finger, okay? Right? Some of you guys want to give me the middle finger, but all right, so that's the long finger, right? The middle finger, long finger. And then what's the next one? That's the ring finger. Why? Because that's where you put your ring. Okay? And then the pinky finger. All right? So when we go forward from here, you know, pinky, is that acceptable? I'll accept it, because sometimes people use the term, what's the other term for pinky finger? Small finger, okay? So just get that terminology common in your head, okay? SF is small finger. Okay, so then you have different phalanges, right? So the index finger through the small finger, right? Rock on, right? Those between those two has 3 phalanges, correct? Okay, and the thumb has how many? 2. So keep that straight in your head, okay? So phalange starts with a P, correct? So if you see SFP1, what do you think that means? Small finger, first phalanx. Okay? Make sense? So when you get a read back from radiologists and he's trying to pretend he's an orthopedist, that's what that means. Because that's how we talk. Make sense? When I document it, I don't like words. I like acronyms. Right? Some of you guys have seen the ortho note. Internal medicine note, laundry list. Ortho note, I can't even make the smallest amount possible to show you guys. It's a small note, right? Because we abbreviate everything we can. So if you see that, that's what it refers to. Any questions? So 1 is the most proximal. P2, so P1, proximal. P2 is middle. And P3 is distal. Okay, so if you hear, that's a good question, thank you. So if you hear distal phalanx fracture, which one is that? P3. You see how these things are used interchangeably? Okay, don't worry, you'll get this again. Okay, we'll talk about all this kind of stuff again. I know what your bandwidth is. I'm trying to stay within it. Okay. Clavicle. So when we talk about clavicle, it's important for you guys to understand this anatomy. All right. So the acromion is on which side of the scapula? Anterior. Okay. As it shows there in the picture. Okay. So is the coracoid process, correct? Yes. Anterior, correct? Okay? So if you're looking at an x-ray and you can't tell whether you're anterior or posterior, your anatomy will tell you. And that'll become evident when we start talking more about radiographic views, okay? Well, otherwise, what's on the posterior then? The spine of the scapula. So if you're looking at an x-ray and all of a sudden you see the spine, but you don't see either the acromion or the coracoid, which side are you on? You're on the posterior aspect of the scapula, correct? Make sense? Do you think that just because you order an x-ray and you're like, this is what I told them to do, that they shoot them the way you want them? No. Hopefully all the time, right? But you do have the ability in the radiology system to flip the image. Okay, so if somebody has gone in there and sabotaged you, right, and flipped the image, you should be able to tell. And how do you tell? By knowing your anatomy. Okay? If you guys haven't heard it enough from me yet, anatomy is power. If you know your anatomy, That's a strong tool that you have at your disposal, because then you can decipher things that, you know, you're like, I haven't looked at an x-ray like this for a while, but I know my anatomy, right? Which vertebrae has a rib on it? Thoracic vertebrae, right? So when you were asked to find L1, you just look for the first vertebrae that doesn't have a rib on it. And that's how you found it, right? Yes, most of you, okay? But you understand that if you understand anatomy, that then you can decipher things, right? Okay? Questions about that so far? No? All right, so those are some like key landmarks that's going to become important when we're doing physical exams and when we're starting to talk about some of the radiographic imaging, okay? So the head of the humerus, that's the humeral part of the glenohumeral joint, correct? So you notice how there's that white kind of frosty flake, crusty covering there? Crusty covering? That's what I meant to say. Right there? Do you think that's cartilage?
Yes.
That is cartilage, okay? So do you think you can have arthritis there? Yes, you can have glenohumeral joint arthritis, right? Just same as you could have in a knee, okay? Now you look on the other side of the glenoid, and that looks to be white crusted as well in that picture, right? Frosted, I'm thinking of frosted flakes, I don't know why. Right? So you can have cartilage breakdown on both sides, right? So arthritis can be either on the glenoid side or on the humeral side. Are we good with that? Okay. Okay. So as we get into our x-rays, that's what we're looking at there. How do I know that's an anterior view? Do you see well, I mean, it's labeled, right? But do you see the coracoid? That's not labeled, right? Everybody sees the coracoid? So you know you're anterior, correct? You're looking at an anterior view, okay? Normal radiograph AP. You know it's that because it's labeled that on the slide. But do you know, does it normally say that on the image itself? No, it does somewhere that's the text at the bottom or the top, right? But you look at the marker there, and which side is it? Left. That's what the L stands for, correct? All right, good. So you know that you're looking at a normal radiograph, anterior posterior projection, that's what AP stands for, of the clavicle, okay? So what kind of injuries do you think you're going to get a clavicle view of? Trick question, okay? All right, sort of. All right, you'll get it for clavicle fractures, okay? Now, AC does have its own particular views as well. Do we sometimes get clavicle views and AC views?
Yes.
We do, okay? So understand, again, if you're trying to get a full-length view of it, then you can get both, okay? And we'll talk about some specific AC joint x-rays that we would want to get, okay? So, excuse me, do you see the shoulder in that x-ray too?
Yes.
The glenohumeral joint, a little bit? You see a little bit of it, right? But it's not a dedicated view of the actual glenohumeral joint, correct? So if you had somebody who sustained a dislocation of their humeral head, right? Shoulder dislocation, that's what it is. And you had a clavicle fracture too, would you get x-rays of both?
Yes.
You would, because you guys are good, okay? So a normal radiograph of the clavicle, so this one is an AP, this is a radiograph as well, it's labeled normal radiograph. That is what it says right there, 15 degrees cephalic view. Everybody understands the difference between cephalic and caudal? Okay, review your medical terminology if not. So one view is looking up a little bit. What is that up? 15 degrees. And one view is looking down. Why is that? You guys have seen a clavicle before, right? So you understand now that we use terms like convex and concave. You know that the clavicle is curves, right? Clavicle curves. Right? There's a convex and a concave aspect of the clavicle. So if you want to get a better definition of this bone because it exists in multiple dimensions, then you might get a 15 degrees cephalic and a 15 degrees caudal, excuse me, to get a better view of that. That's all that means, okay? Questions about the clavicle? Okay, is it coming? Is the information coming too quickly? No, you were saying yes at first. Okay, you changed your mind. Okay, AC joint. Now this is AC joint. Now notice how it's different. It's not the same, right? Because they're in different sections of the lecture, okay? So understand that the AC joint doesn't necessarily have the same anatomy that the clavicle does. Which end of the clavicle has those ligaments that go up and down? The lateral or distal, right? Right, it's more lateral or more distal, correct? So those ligaments that are right there attached, okay, and right there attached, and right there attached, you see that? Those ligaments there? Okay, just understand that they exist. I'm not going to necessarily test you hardcore on that, but just understand that's what causes an AC joint injury, is that those ligaments are injured. Therefore, you have AC joint instability. Have you guys heard that before? Okay, good. So that's why you want to get an AC joint view if you have an AC joint injury concern and not just a clavicle fracture. Okay, because that'll tell you the relationship of the actual clavicle to the coracoid. Have I lost anybody yet? Okay, if you think that those ligaments are disrupted there, that clavicle will go south, north, excuse me, will go up. It will. Okay, so that'll tell you that relationship. Make sense? Okay, we good so far? All right, so AC joint view. It looks a little bit like a clavicle view, but you see how it's zeroed in on the AC joint itself, the acromioclavicular joint. Okay, again, when you get imaging, it should be zeroed in on the joint or the anatomy that you're concerned about evaluating. Good to go? Okay. Do we have any radiology techs in here shaking their head? No radiology techs in here? No, nobody wants to fess up. Okay, fine. AC joints. So do you think if, again, does that look like a normal view? Yes, because it's labeled normal. Okay, but then we'll start talking about abnormal. And again, you're going to see that because you get this view. Okay? Can you get a cephalop view as well? Yes, you can. Okay? Would you agree that you can see a little how that looks more horizontal and straight? You can't really see the curvature of the clavicle in that view? Okay? Everybody agrees with that?
Yes.
Who disagrees? Nobody? Nobody wants to fess up. But then when you come here, you can see a little curvature right here to the distal end of the clavicle. You see that?
Yes.
That's why you get that view looking at it from a different angle. Okay? So this one says what? Normal bilateral AC joint with and without weights. Tells you everything you need to know right there. When you get views of the AC joint, right? Remember we talked about how somebody can be loosey-goosey in anatomy, not character. And so if you're looking at a view and you're like, is that a little elevated? Does that look a little unstable? What's the best way to compare it? The other side, right? Right? Would you agree, of course you will, that if you put weights in someone's hands, have them stand up and shrug a little bit, and then shoot the view, that if it's going to displace, it will displace?
Yes. Yes.
Okay, so then you do it with and without weights. So not only are you comparing it to the other side potentially, right? But you're comparing it with and without weights to see if there's any joint instability. Joint instability is something that I want you guys to start getting used to that terminology, okay? Pain is something very people commonly associate with orthopedics. We are the worst at treating pain. What is it that we do when people come see us? We do surgery. Is that painless? No. So pain is not always the best way to think about orthopedics. We love instability though, because we can make that different and hopefully better. Make sense? So this is what I'm looking here for here. I'm not looking to see if this causes them pain. I'm looking to see if this causes them instability. Good to go? Questions? Shoulder joint, this is redundant, but again, when we start talking about the shoulder joint, we're only talking about very focal areas. That's the reason why when I talk about shoulder joints, I say glenohumeral joint. Because I'm talking about the humeral head in relationship to the glenoid fossa. Everybody agrees that the glenoid fossa is the cup side, right? It's the recess on the scapula that the ball, otherwise known as the head of the humerus, sits in. Okay, so that's the relationship when we're talking about glenohumeral joint. Good to go? A lot of words here, okay? But I will tell you that I would spend some time with this, and we'll zero in a little bit more during the lab on this, okay? But just understand what is the terminology here? Greater tubercle, right? And lesser tubercle, okay? Can you have patients sometimes that when they rotate their humerus in, everybody do this, right? Rotate your humerus in, then maybe you'll see a different tubercle depending on how it's rotated. Okay, so you know that you're looking at a normal AP radiograph of the shoulder when the relationship of the tubercles looks like this. The greater tubercle is lateral, and the lesser tubercle is what? Medial. If you rotate inwards, would you agree that the greater tubercle then becomes medial? Of course you do, because that's what happens. Okay? So you see what I'm getting at here. Okay? So it's important to understand the position because our shoulder x-rays, it's not just one, it's not just two. It's very commonly 4. Okay? Good to go? So that's the thing that's important about this. Go through it, understand the anatomy, okay? But really pay attention, please, to the greater tubercle and the lesser tubercle, okay? So what's the groove in between? Well, it's appropriately named, right? Intertubercular groove, okay? Makes sense? Okay, good? Any questions about that? Of course not. So this is a normal AP view. Do you see the greater tubercle right there?
Yeah.
Yes, and right there. Right? That's the greater tubercle, right? So I know that that's a normal AP view because the greater tubercle is lateral. Can you really make out the lesser tubercle? Not necessarily, but you would agree that since it's called the lesser tubercle, it's smaller, so it shouldn't look as prominent as that does?
Yeah.
Okay? Probably if you do some resolution, or maybe you see it better on your screen there, or you should be able to make out the lesser tubercle. It's actually where? Right there. Correct? Okay, right there and right there. Okay? Good to go? So that's how you know. Okay? So this is an axillary view. That image right there shows you how this image is shot. It's called an axillary view because they shoot it into the axilla, otherwise known as your armpit, correct? Okay, so this is the position you want to shoot it in. Does a patient, excuse me, that sustained some kind of trauma to their shoulder always want to get into this position?
No.
No, but this is one of the 4 views that you'll get if possible. I will teach you a view that you will get regardless though, because it doesn't require you to lift your arms into this position. Okay, why is this important to understand? What in the world is this structure right here? Okay, so is that anterior? Okay, I was saying this structure right here, sorry guys. Right there, right? So I already explained to you guys that if that's anterior, from this view, can you tell if the head of the humerus is anterior to the glenoid?
Yeah.
So therefore you would agree too that you could possibly tell that it's posterior to the glenoid. Okay, so that's why your anatomy is important here. Because if you don't understand that normal anatomy, you'll be like, I don't know what I'm looking at. Right? Doesn't look like a fracture. You're not always looking for fractures, right? I used the word instability, dislocation before. Okay, so that's not necessarily everything you're looking for. Are we good with that?
Yes.
You see how the anatomy becomes relevant, right? So this is a true AP. The other one was an AP. This is a true AP. Why is this a true AP? I'm not going to really nitpick with you guys about this. The reason it's a true AP is because you have a good, excuse me, on this one here, you would agree that you can see the glenoid fossa there, right? Now, if you go to a true AP, right, it's shot in a different angle, you don't see that depression there. It's just the relationship of the glenoid, right, the glenoid on this side, to the humeral head, correct? So you're looking for different pathology with that, okay? When we start talking about, everybody understands that? Sorry, I'm going really quick on that. So instead of seeing the depression of the glenoid, now you're just seeing the profile of the glenoid, okay? So if you're looking for fractures of the glenoid, sometimes you get this view instead. Okay, again, just understand that there is a difference between a true AP and an AP, okay? Are we good with that? Okay. And this is the view I was talking about. This is a lateral view, wide view, okay? Let's go again with anatomy. Okay? What in the world is this structure right here? And right here? Right there. That's the acromion. So therefore you know it's anterior, correct? Does this view require you to lift our patient's arm up? It does not. You can shoot this view with a patient with their arm at their side. Okay? So you see the Y there? That translates to the Y here. The Y here, right? It translates to the Y here. So what you're looking to see is that the head of the humerus is in the center of that Y, right? And it's not anterior to the acromion or posterior to that Y, right? So then with this view, without having to put the patient into a certain position, you can just say, I think there's an anterior dislocation. Is that what's evidenced in these pictures here, guys? Right, so when you look at this picture here, right, that's just showing you the Y with the glenoid taken out. When you look at this one here, right, what is that showing you right there? That's a normal lateral, right? Okay, so this one is a posterior dislocation, and this one is an anterior dislocation. Why? Where's the acromion? Right, so this one, guys, over here is the posterior dislocation. This one here is an anterior dislocation. You see how the acromion here meets the head of the humerus? Is that a normal relationship? No. So the acromion here meets the head of the humerus here. That's not a normal relationship, correct? So then you know you have an anterior dislocation, and you did not have to put the patient into a position of discomfort or pain. Good with that? Okay? So that's what's going to happen. You guys are going to send somebody down for x-rays, and the radiology tech, if there's one in this room, don't get mad at me, secret people, all right? But they're going to go down there and say, patient was in too much pain to get an axillary view, right? Patient was in too much pain to get an XYZ view. What's the one view you should get if you're concerned about a dislocation, though?
Lateral.
The lateral Y view. It does not require the tech to put the patient into any pain. Make sense? Okay? Do you think that I'm going to foot stomp on this? Yes, because again, you know, you guys have kind of zeroed in on my methods. If I go through something in detail, you'll probably see it again. Okay? Because I think it's important for you to understand this. Because you're sitting in your primary care clinic, you call me on the phone, you tell me, I think this patient sustained a dislocation, but I'm not sure. I say, okay, what do your x-rays show? I can't get x-rays because the patient's in too much pain. Unless there's a bone sticking out of the skin, you can get a lateral Y view. Make sense? Okay, then I'm going to ask you, what do you think? Is the humeral head anterior to the Y? Is the humeral head posterior to the Y? And astute clinicians you are, or are becoming, you will tell me. And then I'll say, okay, good luck relocating it, call me later. I'm busy. No, I'm joking. But that lets me know that there's a relocation that has to occur, right? So what view do you think we're going to get after where you relocate the shoulder?
Another lateral Y view.
Another one, because do you think I want to put the arms up and dislocate them again? No, so that's why it's important to understand this is a very valuable view, okay guys? Spend some time with this, okay? Did I explain it decent?
Yes.
Okay, not the best.
15 survival.
Okay. All right, normal MRI. Memorize all this. You need to know all this. You're going to be shown a question with 181 slides of MRI. No. Okay, that's not true. You know that already, right? Well, somebody didn't trust me, but I hope you do a little before now. Well, one thing I do want you to know is what is this right here? Yeah, acromion. Okay, right here, guys. All right, that's acromion. So this space that's underneath the acromion, between the acromion and the head of the humerus, is what is called what? Subacromial space. Okay, and in that subacromial space, we'll talk about, now it's upper extremity, right? We're going to talk about rotator cuff muscles. You see that where it's labeled supraspinatus tendon? You see how the supraspinatus tendon runs through that groove that's underneath there? Okay, so do you think if the acromion is pinching down, impinging, if you will, on the supraspinatus tendon, then it can cause impingement?
Yes.
Okay, have you guys heard of the term impingement syndrome? That's what that is. Okay, so I think this is fair game. Okay, because it's just understanding where the supraspinatus is important. Okay, right? But I'm not going to give you MRI questions otherwise. Okay, because is this radiology course? No, but it is important for you guys to understand what the heck I'm talking about when I start talking about radiology with radiographic findings. Okay, are we good with that? Am I going to ask you what the inferior glenohumeral ligament is?
Hopefully not.
No, unless you want a 51 question test, let me know. Okay, so, but this is a different view, okay? So when we're talking about this view, let's back up a little bit. When we talk about this view, you would agree that when we talk about advanced imaging, do we use things like AP? No. This is a coronal view, right? From the front, slicing back. Front to back. Does everybody agree with that?
Yes.
Everybody understands the different planes from radiology? Right? So what is this view? Actual view, correct? Okay. So this is a better view for looking at the biceps tendon, the long head of the biceps. Long head of the biceps. Which head?
On head.
Because it does have a short head, right?
Yes.
So long head of the biceps. Everybody, I mean, it's labeled, guys, but it's right there. You see that groove? What do you think that groove's called? The bicipital groove. Okay, so that's what we look at to see if there's biceps tendon pathology. Okay, if there's no biceps tendon in that groove, do you think there was an injury?
Yes.
And we'll talk about that injury. Okay, guys? Right, so that's why I think the one thing I would focus on this view. Okay, am I going to ask you where the inferior, the infraspin is the subscapularis muscle is, middle humeral ligament? If you want 52 questions, let me know. Okay. So what view is this then? Okay. So then we're cutting another view here. Okay. So when you're looking here and you see these relationships here, you see how fuzzy that is? That's why I don't give you MRI views, okay? Because it depends on the imaging, okay? It depends on the resolution. All right. But you see how you can see different pathology there. Do you think that you order MRIs for tendinous injuries? That's when you order MRIs, correct? It was in the slide before. Confirmatory. Think words like confirmatory, words like soft tissue injuries. Is a muscle and a tendon soft tissue? 100%. So this is why we're talking about this, because now we're going to start talking about what kind of studies you order for different injury patterns and upper extremity injuries. Okay. Humerus. So humerus is the long bone. That is a long bone. That is a true long bone. Okay? If you have a humerus fracture, that's a significant fracture. Okay? Good to go? Good. All right. So humerus, does that, like we talked about before, the greater tubercle, right? That's a tubercle, but that's on one end. What about the other end? Do you have condyles on the other end? Right? So do you have a medial and a lateral condyle? You do, right? And so those little nubs on the edges of the condyles are called epicondyles. Okay, so when we start talking about epicondylitis, right, that's the area that we're talking about, the medial and the lateral epicondyles. Okay, so it's important to understand that. Okay, so you see what that area right there where it says olecranon fossa. Okay, what is a fossa? It's a groove that something else articulates with or inserts into. Okay, so do you think that the olecranon goes into there?
Yes.
Yes, it does. Okay, so it's important to understand that too, because you know where the anterior and the posterior is based on whether you're looking at the olecranon fossa or which fossa? The coronary fossa. Okay, you see how you can quickly tell, right? If you don't have a view that shows you the tubercles, you can tell which side you are, whether anterior or posterior, based on the fossa that you can see. I don't expect you to fully appreciate that now. All right, but hopefully you will when you guys go out to phase 2 and you beg and plead to look at every x-ray you can. Because that's the only way you're going to get good at it. Okay? Make sense? Okay. All right, so it's a long bone. Do you think you can get the entire humerus on one image on every patient? No. It was very nice of them to be able to do it here, but that's not always possible. Why do I tell you that? Because if you have to get 2 images to get the entire span of the humerus, that's what you have to do. Okay? When I go down for a trauma case in the emergency room, patients screaming, writhing in pain, all this craziness, they give them some pain meds. I put lead on, I grab plates, me and the x-ray tech, I hold the plate, I position the arm, and I get one end of it, right? Then I take it and I position and I get the other end of it. And then they process it and I look at the entire thing. Okay, because can you have fractures on either end of the humerus?
Yes.
100%. I can tell you right now, you know, you guys like lifting your arm over your head, right? Reaching out, things like that. So it is pretty cool, huh? So if you have a fracture that's significant, that's affecting those bony landmarks where the muscles and tendons attach, you can have significant loss of function, correct? So it's important for us to identify these fractures. And if there's any question about it, you laugh at me? If there's any question about it, then what kind of imaging do you use to look at intra-articular bone pathology? CT, right? So that's, remember, all that learning is coming together, I hope. You're not just laughing at me. Okay. So that was what? This was an AP, and this is a lateral view, okay? Trick question, or I'm trying to prevent this, you guys from getting tricked by this question. Can you see the elbow joint in this view? Yes. Okay, you can. Does it look like a lateral of the elbow? It does. Is it, now here's the $100 question, is it a lateral of an elbow? No. Do not let the whomever, I won't throw the x-ray tech on the bus this time, but don't let them tell you, well, you can see what you need to see, you're good. Okay? It's not sufficient. Okay, here you go. All right. Elbow joint. Now, we're talking about elbow joint. Okay? So elbow joint, this tends to be something that I really hope you guys start spending a little bit of time on, just reviewing, making sure, because the radial head is proximal to the elbow, right? Would you agree? Of course you do. So when I say radial head injury, and I describe it to you, you should understand it's not near the wrist or the carpus, right? So the radial head is proximal to the elbow, therefore is part of the elbow joint. Okay? Because then we start, later on, we'll talk about distal radius fractures. Okay? Distal radius fractures are not radial head fractures. They are not. They're treated differently. Okay? Because distal radius fractures articulate with the wrist, not the elbow. Are we good with that?
Yes.
So why do we talk about radial head? It's a very commonly fractured injury pattern, in adults and also in kids. Okay, we'll talk about a term or a diagnosis called nursemaid's elbow. Some of you guys have heard of this before. Okay, so again, when we start talking about that pathology, understand what age population we're talking about. Okay, you can see the condyles there, right? Or at least on the view there, because you're looking at a lateral epicondyle. Okay, everybody sees it? Okay. So then when we scroll forward and we say, okay, when we're looking at anatomy, right, do you see that olecranon fossa there? It's right there. Because this is the ulna, right? Isn't the olecranon this portion right here? The bony thing, your funny bone? It ain't so funny when you hit it, is it? Right? But that's what you're looking at. So if you extend your arm like you would in an anatomical picture, because everybody walks around like this, right? Then you agree that that's posterior, right? So when you're looking at this view, are you looking at any of the anterior structures? You are not. So it's important to understand that, okay? So when you're looking at this view here, I mean, it's labeled, right? So it's the left side. But so then if that's the left side, take your arm out and extend it, right? You're looking at it from behind, right? So which side is medial and which side is lateral? Get that in your mind, okay? Because that will throw you off. Because you think you know what you're looking at, but remember, this is a left, right? But you see how it's more of a bony prominence there? So that's kind of an indication, right? You see that?
Yeah.
More right there? Looks like more of a bony prominence. So that tends to be your epicondyle. Okay? You good with that? Everybody knows that the forearm has two bones, right? The ulnar and radius. Okay? So you can only see the proximal ulnar radius in this view, correct? So if you want to get a view of an entire forearm, which kind of x-rays do you order? Forearm x-rays. Okay? This is the lateral view of an elbow. I can tell you right now, the bane of orthopedics for some people is getting the true lateral of an elbow. Okay? Especially in kids. Okay? Because kids have open growth plates, right? Those physes that are open. So a lot of times it's more difficult to see those structures. Okay, but you see that what is this right here? I mean, it's labeled, right? So that's the radial head, correct?
Yes.
So understand that the radial head is proximal to the elbow joint. Okay? And then the tuberosity of the radius is another structure I want you to get kind of familiar with, and we'll talk about it, right? Because that is where that long head of the biceps that we talked about before, that was on the humerus, on the proximal end, right? Well, on the distal end, where does it insert? At the radial tuberosity. Are we good with that? Okay, so if you get an x-ray like this and you see a piece of bone pulled off here, right? You guys know what avulsion fractures are, right?
Yeah.
Avulsion injuries, okay? So that, then if you get this view and you see that, are you suspecting that potentially they could have a long head of the biceps tendon rupture? Yes, at least some kind of injury, okay? Are we okay with this picture? Okay. So this is very special view. I will foot stop this because does pants love mnemonics and like names, special names? They love it. Okay, so it's a radial head view. So if you have a hard time looking and seeing the actual profile of the radial head, which you guys would agree is this right here, correct? That and this right here? Okay. So let's go back to the view. Right there, it's kind of obscure. We call this double density. It's two bones overlying each other, right? You see that right there? There's two bones overlying each other. Okay? So if you want to get a better profile view, you get this view, where you can see the entire articular surface of the radial head. Well, that view is called a Greenspan view, or a radial head view. Okay? Greenspan is the fancy term for it. If you're looking for Greenspan in Genesis, you probably won't find it. Right? You may have to order an elbow x-ray and then specify in that order Greenspan view. Okay? I tell you that because it's not a very common order. Okay, but if you're concerned about a radial head fracture, he said it like 5 times now. So if you're concerned about a radial head fracture, which view are you going to get? Okay. Don't worry, somebody will get it wrong. All right, so I'm joking, sort of. So normal CT view, useless. That's only one slice, right? But you see how you can see the relationship on the right side is the CT, right? Everybody agrees? You can see that relationship again, okay? And you see a better definition of that distal end of the humerus? Not as much double density to deal with, right? Overlying bones and things like that, okay? So I think of x-rays, and some people think of x-rays as an initial screening tool, right? If you want the high-powered x-ray, that's a CT, right? Is that okay? Are you okay, sir? Sure. All right, forearm views, let's not spend too much time with this. But just again, take a minute to look at this. Where is the styloid process of the radius? Is it proximal to the elbow or distal to the elbow? Distal to the elbow. It's on the distal end of the radius, and the radial head is on the proximal end of the radius. So therefore, the ulnar styloid is right next to the radial styloid. Okay? They call it the styloid process of the radius. We literally just call it the radial styloid. So if you think of it as a radial styloid and an ulnar styloid, those are both on the distal end. Okay? Good with that?
Yep.
Okay. Forearm views, you get the entire span of the ulnar radius, correct? Okay. You see a little bit of the elbow, but is that a good view of the elbow?
No.
Dude. So, I'll introduce a concept to you now, okay? When you have an injury to one part of the body, you x-ray a joint above and a joint below. Okay? So, especially in trauma. Someone comes to the emergency room and gets evaluated, and they call me and say, I got forearm views, and I see a fracture of the radius only. They say, great. What does the wrist views show? And what does the elbow views show? Is that a joint above and below? Okay, so that's an example, right? When they tell me they don't have it, I say, I'm sorry, you're breaking up. Can you call me back when you have right freaking x-ray? Okay? Because I want a joint above and below. Okay? Good to go? A lateral view, can you see how when you have a lateral view, the ulnar and the radial styloid overlap. You can't really make out one compared to the other. You see that? You see how those styloids, those distal ends of the ulnar radius overlap? That's how you know you have a true lateral of the ulna, of the forearm, right? We'll leave it at that, the forearm, okay? Good to go? Okay. All right, stick with me. Wrist, okay? So long to the pinky. Here comes the thumb. Okay? That's one way of remembering it. Okay? What am I talking about? Right? So we have these bones here. Scaphoid, lunate, triquetrum, iciform, trapezium, trapezoid. No one's going to join in? Okay, capitate, handmade. Okay? All right, good. But I want you to understand, now we're at the wrist, not the elbows. Please, for the love of God, listen to what I'm about to tell you. When we're talking about elbows, medial and lateral works. When we're talking about wrist, what terminology are you guys going to use?
Ulnar and radial.
Ulnar and radial, okay? So would you agree that the scaphoid is on the radial side? So then you use your acronym and you work your way across, right? And that's how you remember your bones, okay? How do I remember trapezium versus trapezoid? Spell them out, okay? If you spell those out, would you agree that if you're doing alphabetical order based on the letters, that when you get to the Z in both trapezium and trapezoid, that the I comes before the O?
Yes.
You would agree. Thank you. And if you're on the radial side and you're working your way from radial to ulnar, that the trapezium follows it follows it or it precedes the trapezoid? It precedes it, right? Trapezium is most radial and the trapezoid is more ulnar. Would you agree with that? Okay, and the other bones you just have to remember them. Okay? Alright, those are the two that confuse people. Okay? But the scaphoid is a very important bone to understand because it's very commonly fractured and it has very, very common complications of non-operative healing and operative healing. You guys learned about that a little bit maybe?
Yeah.
Retrograde blood supply, things like that? Okay, I'm not going to drill down on that, but if I ask you where the scaphoid is, do you think during your lab that I will talk about snuff box tenderness to palpation? Yes. So you know that that's a good, when you have snuff box tenderness to palpation, I'm running out of juice, that then you're concerned about a scaphoid fracture, correct? So it's important for you to understand where that is. Okay? So is the scaphoid radial or ulnar? Oh, I beat that horse to death. Okay. I don't know why there's a problem there. Okay, it's a little bit more of the same, okay? But just down on this because if you like the yellow star, right? The yellow star that asks you what it is, right? So it's a yellow star over one of those bones. You gotta, in your head, figure out how to remember that. Okay? I know this is being recorded, but this is a very common way that we remember things. Okay, so I'm gonna go ahead and test the waters again and see what happens. Some lovers try positions that they can't handle. That's how orthopedic people remember the bones of the carpus, carpal bones. So long to the pinky, here comes the thumb. I can't remember that. Doesn't make sense. But again, some lovers try positions that they can't handle. Okay? Now you'll never forget it. Okay? I survived one semester without getting written up. All right, so that's a wrist, right? There's still an overlap of the ulna, the distal ulna, and the distal radius, correct? But now it's centered on the wrist. Yes, that's fine. Hopefully you won't forget on the day of the test. Okay? This is an oblique view. Would you agree that the distal end of the humerus, everybody paying attention? Distal end of the ulna and the radius are not overlapping in this. They look like they're oblique to each other. Well, that's an oblique view. Okay? Good to go? Clenched fist view. When did we get clenched fist views? Did you guys learn this? Yes, scaphoid. So let's use our terminology. You would agree this is the scaphoid, right? Some lovers, right? There we go, I'm going to get myself in trouble. So scaphoid lunate, right? Scaphoid lunate, right? So when you clench, right, and you have both wrists on one plate, that's what you're looking at there, one x-ray plate, okay? If there's instability, there's that word again, instability of the scapholunate ligament that you'll have widening of that space between those two bones. Okay? Why do you get both sides on one plate? To compare, to see. Because some people have physiologic normal widening. Okay? Are we good with that? So this is a view that you may get if you're concerned about a scapholunate injury. Okay? We're good with the anatomy? Normal CT of the wrist? Of course it is. I won't show you that. Okay? This is the relationship of the wrist on the lateral view. You see how the distal end of the ulna and the distal end of the radius overlap? Right? So then we have the capitate and the lunate, correct? Or the lunate or the capitate. Okay? Everybody knows what a moon is, right? Everybody knows what a half moon is, right? Is that a half moon right there?
Yeah.
So which bone is that?
Lunate.
Okay, what's the bone that's distal to that one? Capitate. Hamate? Which one is it?
Capitate.
Okay, I agree with you. And then what's that bone right here? That's the fifth metacarpal. Okay, so those things should line up. That's that relationship on that lateral that you're looking at. Okay, if that yellow circle bone, which is what again? The lunate is what? Anterior or posterior and not in good relationship with those other bones, then you have a dislocation. Okay? You need to reduce that? Yes. And a lot of times you may have to do surgery to do that. Okay? I'm not going to drill you guys down on this too much. But just understand that the cup should open towards the metacarpals. What does it mean by open? It means that the open end, right? The open end on this end right here should be towards the metacarpals. Right there. Everybody understands that? So if it's not, then there's something wrong. That's a whole area that I could spend a month talking to you guys about and not even scratch the surface. Okay? That instability that I just mentioned, there's all kinds of different instabilities. Okay? And we're almost done, I promise. So we kind of already did this. We talked about the hand, right? Okay. So when we talk about hand x-rays, you would agree that this is zoomed in on the hand and not the wrist.
Yes.
Right? So if you have a hand fracture, you're going to get a hand x-ray. Oh, and by the way, if you're getting a hand x-ray and there's only one specific finger that's injured that you want to look at, what kind of x-ray are you going to get then? Finger, right? So lateral view, the one thing I'll tell you, how do you know this is a true lateral? Do the metacarpals overlap here?
Yes.
They do. That's a metacarpal overlapping. All those right there, right? Does the thumb metacarpal overlap? No. So which one is that? Rock on. That's the index finger through the small finger. Are we okay with that?
Yes.
Where's the first metacarpal? It's not there. It's right here. Right? That's the thumb, right? CMC, we talked about that already?
Yes.
Okay? That's it? Any questions? Don't leave yet. Any questions? No? That was a lot of information, I know. But that's your brief overview, okay?